Hi, I'm Andrea Fisher, PGY2 in vascular surgery at Stanford, and my presentation is Congestive Heart Failure Outcomes and Mortality After First Arteriovenous Access Creation. Heart failure is often comorbid with ESRD, and these patients frequently require permanent hemodialysis access, so this usually means a fistula or a graft. Arteriovenous fistulas result in elevated venous return, which can worsen heart failure. We investigated the impact of first-time hemodialysis access and comorbidities on markers of cardiac function and mortality. Santa Clara Valley Medical Center surgical records were reviewed for patients receiving first-time AV access between 2015 and 2022. Patients were divided into non-heart failure and heart failure groups with reduced ejection fraction and preserved ejection fraction subgroups. Pre-op heart failure was defined as clinical diagnosis and a left ventricular ejection fraction of less than 50% in the case of HFrEF, or diastolic dysfunction in the case of HFpEF on pre-op echo. We included all patients with HFrEF and a random sample of patients with HFpEF and non-heart failure. The total number of patients included was 346. Ejection fraction was used as an overall marker of cardiac function or heart failure severity, and right ventricular systolic pressure, or RVSP, was a marker of right heart function that we used. Paired t-tests were performed for differences in ejection fraction and RVSP before and after arteriovenous fistula or graft creation. And then Kaplan-Meier analyses were performed for mortality curves, and univariate analyses were performed to identify variables correlating with mortality. For our results, compared with non-heart failure patients, HFrEF patients were more often male, former smokers, and had a history of COPD and prior stroke. HFpEF patients had higher BMI on average and were more likely to have a history of diabetes, hypertension, and COPD. For changes in ejection fraction and right heart function after fistula or graft creation, we found decreased ejection fraction in the non-heart failure group and the HFpEF group. So for non-heart failure, that was a change of 3.5% with a p-value of 0.013, and for HFpEF, it was 1.9% difference with a p-value of 0.047. We found an increased ejection fraction in the HFrEF group after arteriovenous access creation. So that was 4.3% with a p-value of 0.002. We did not find any differences between pre- and postoperative right heart function for any group. For length of survival, all three groups are pretty similar at 1 year, around 90%, but at 3 years, we start to see some divergence. So for the non-heart failure group, it's 80%, for HFpEF group, it's 70%, but for the HFrEF group, it's about 58%. And then at 5 years, we see even more divergence. So for the non-heart failure group, it's 64%, for the HFpEF group, it's 60%, and the HFrEF survival was 47% at 5 years. The p-value is 0.0038 for non-heart failure versus HFrEF survival, and differences between the other curves did not reach significance. For predictors of mortality, we found that radiocephalic fistula was actually protective against mortality. So this was a hazard ratio of 0.58. And then earlier mortality was associated with both varieties of heart failure, as well as a history of stroke and former smoking. In conclusion, we found that first-time dialysis access creation did result in EF decreases in patients with preserved ejection fraction and those without heart failure, but it did seem to improve ejection fraction in patients with HFrEF. Patients with HFrEF experience earlier mortality after first-time dialysis access compared to those with HFpEF and without heart failure. RVSP was not affected in any group, suggesting a minimal impact of fistular graft creation on right heart function. Radiocephalic fistula was protective against early mortality. And in addition to heart failure, history of smoking and stroke portended poor survival after access placement. So some avenues of future investigation for us are: why are radiocephalic fistulas associated with increased survival? Are they themselves protective, or is it that patients who have a larger cephalic vein caliber are healthier at baseline? If right heart function does not mediate changes in ejection fraction after a fistula or graft, what mechanism does? And finally, is there a CHF severity threshold past which we should leave patients with a tunneled line and not pursue permanent arteriovenous access? Many thanks to the County of Santa Clara Valley Health System for their support of this work, and thank you so much for listening to my presentation today.